I think it's been a very interesting last 2 days. People from very different backgrounds and with different intents have come together. So this concluding session hopes to pull all the strands together, and maybe when we leave from this hall, we take home some primary learnings, but also listening to this panel of speakers may give some deeper insight as well. So I hand over to Werner Surs. Werner, the floor is yours.
Thank you. Good afternoon. It's an honor and a privilege to facilitate this last session for 333 researchers, policymakers, students, nice people all. Among these people, we selected 6 in this panel. I will very shortly present them because you already know them most likely. I will start with Dr. Deva Dasan. He's director of EPHP Bengaluru, organizer and driving force behind EPHP. I think he needs a hand. Second is Dr. Bruno Grijzeels, director of ITM Antwerp, co-organizer of EPHP, very much in line with having been the driving force of the 2001 Healthcare for All Antwerp Declaration. Third is Dr. Sundararaman, who is former director of State Health Resource Center Chhattisgarh, where he co-started with others the Mitanin, and currently executive director of the National Health Systems Resource Center. Fourth, finally a lady and new in this panel, is Dr. Mbina from Indian Administrative Service, currently Mission Director of Nrhm in God's own country, Kerala. Do I miss Dr. Visha? He's not here?
He's not here. He's not here.
Dr. Visha is not. We also had normally a foreseen mission director of the one state, many countries governors of Karnataka, but he could not make it. Then we have, last but not least, Dr. Ravi Narayan, whom most of you know of Jan Swatya Abhidian, but also member of WHO Advocacy Circle of People's Health Movement and member of Task Force Primary Healthcare of the Planning Commission of India. Let me very briefly state what we are going to do. In all of the sessions, you have seen very hardworking guys and girls in one corner who were rapporteurs and who noted whatever happened. These notes are now synthesized, and you will get a synthesis by Dr. Deva Dasan. After that, I will ask all the other members of the panel to sharpen these things and to add what needed to be added to come to the lessons learned, both for the research community as for the policymakers community. In the very end, we will also ask you if there's anything to add. So let's start with Dr. Deva.
Good evening. I have been given little pieces of paper summarizing the very, very intense and interesting discussions and presentations over the last 48 hours. So I'm trying to make a sense of it, and pardon me if it's not in a logical order, but I'm trying to first look at what are some of the recommendations this EPHP 2012 can make to the research community. And then I'll follow it up what recommendations we can make to the policy makers so that there is responsibility on both sides. I think the inaugural session was very clear in talking about the need for evidence, not the traditional evidence of randomized controlled trials, but a more nuanced health systems research which looks at the context, which looks at the various elements of the health system and the interactions between them. So it is not about what is happening, but it's also about why it is happening, for whom it is happening, and how things can be improved. So that is one key message for the researchers that we need to take home, that it's no, I mean, we need to shift our focus from just doing linear studies, this worked, this did not work, to why it did not work, what were the conditions that to make it work. That was one issue. The second item when it comes, I mean, is for researchers again, is how do we research mixed systems with very pluralistic workforce. When we say medical officer, do we mean MBBS doctors, or do we mean Ayush doctors, or do we mean both? What about the RMAs? What is the role of the nurses? So all this, how do we, when we are doing research on human resources, how do we factor all these into this, into our research? The other is issue about unskilled care, or the less than qualified practitioners. I mean, research into them, what are they doing? Are they disappearing because of Nrhm, or are they becoming more active? This somehow is another area of research that needs to be looked at. The issue on on governance, I think it's very easy. Everybody agreed that a lot more research has to be done because there's not much knowledge about governance. It's a very, very new topic in the health field, and a lot more new, research has to be done on the field of governance. Very challenging area, and hopefully youngsters here will take it up. Right. The role of the community, again, huge gaps, especially when it comes to research and evidence on the role of village and health and sanitation committees. What is the role of the RKS? There's no evidence, very little evidence, and that needs to be taken up in a major way if you want to really look at how communitization can happen. From the Karnataka 2 sessions, one major issue which was coming through was the aspect of quality. Again, saying that it's not enough just to have quantity, numbers, to say we have done so much antenatal coverage, but what is the quality of that antenatal coverage? Again, this has been talked about. I don't think EPHP 2012 is the first one to talk about it, but this is an aspect which is again continuously being neglected and which we need to take it up. And yeah, so then in the health service delivery, there was I'm just reading out because I'm not clear, the micro context of health service delivery and needs to be researched. How is it, so I presume, how is it being delivered? Again, it may refer to quality, but I'm not very sure on this. Maybe the person who's written it can expand on it a little later. Yeah, more research needed for policy intervention to retain skilled rural health workers. So how do you retain health workers? And more research needs to be done. So these are the aspects in terms of the recommendations for the researchers. When it comes to policymakers, one major recommendation, again coming from the inaugural session, was the role of the political role in setting the agenda. Who is setting the agenda? Is it the governments, or is it the planning commission today, or is it the state governments, or is it various other actors? So this, I think each state government needs to be clear whether, because health is a state subject, so they need to be clear who's setting the agenda for their health services. One major debate which happened, especially with Sujata Rao, Madam chairing the session, was about whether government, we should now shift from financing and providing health services to financing and purchasing health services. As many of it, the debate, it was very clear the HLEG is recommending purchasing healthcare. Then what happens to our government services? How do we regulate the private sector? All this was a major debate, and this is something that the policy makers need to come with answers to. Again, for the policy makers, emphasis on quality, saying that it is not enough to say we have so many FRUs working or we have so many human resources per lakh population, but what are these human resources doing? What are these FRUs actually delivering? The quality element again is coming back through and repeatedly. Then in terms of governance, how do we manage decentralization and the resistance to it? The whole divide between planning and implementation. Planning is being done by somebody and implementation is done by somebody. How can, as a policymaker, as an IS officer, either as an MD and RHM or as a health secretary, how can you improve this situation? So that was one challenge for the policymaker. And yeah. And then in terms of health services, the entire silent but important role of the corporate industry. That is the private sector. We are not here talking of the private practitioner in the streets, but we are talking of the industry who is influencing the system through the by having a voice within the system. So how does a policymaker counter that and balance it with the requirements of the community? I think these, as far as I can see, and
Thank you, Dr. David Hassan. Let us now go to the other members of the panel. In the order they are sitting here, maybe. Let's start with Dr. Bruno Gersels. Do you have any additions, any sharpening of what has been said?
Well, thank you, Werner. And first of all, let me say it has really been 2 exciting days. And also before that, I had a few exciting days having my first contact with the Indian health system in the field. And so my answer to you is, in the first place, I have no competence to sharpen what Deva would have said. I am an ignorant novice, both in health systems and in the Indian system. But as you know, sometimes ignorant people can can remark the elephants in the room. I think that's a quite known expression here in terms of health systems. Well, let me first of all thank you, Deva, and your entire team and all the people I have met in the field for the very kind reception I have had and for the many things I have learned in these few days. It also has a word of encouragement. I must tell you that even at the Institute and in the West and elsewhere in the world, we are struggling with the concept of health systems research. Is it a science or is it not a science? My view is it is a science. It's even a very difficult science. I think in comparison with the problem is that it is so complex and that you need so many different angles and knowledge systems to approach it. In one sense, you can compare it, biomedical science is relatively simple. It's like arithmetics, while health systems research is rather like multiple string theory, because it is so extremely complicated. But this should not take away the feeling that, or the conviction that you and we are scientists. there is a saying that says there is no such things as coincidence, there's only ignorance. So many things we do not understand in health systems, but they can be studied if you approach them in the right way. And I must say at this conference, I have been really impressed by the level of the truly health systems research in different ways. First of all, the combination of qualitative and quantitative sciences, and I must say even in general, some dominance of the qualitative sciences rather than the quantitative ones. Secondly, a very huge commitment and high intellectual level of all the participants and all the discussions, but also this remarkable and almost absolutely no artificial link, but a very living link between the grassroots and the different levels up to the federal level. And I think that is one of the major challenges of health systems research, is really to relate what is happening on the ground with those high-level decision-making things. And I am quite confident that health systems research is, as many other things, I'm not going to say a booming business, it would not be right to call it a business, but really something which is very much alive here in India. And I know that you have many problems at home, but please, and many challenges, but please also expose and use this knowledge at the global level, but because we really need it. Not only in Africa and other places of Asia, but really also in Europe and in the United States, where you know that addressing in a different way choices in health care are really probably one of the major challenges of the next decades. So I think you know, I'm not going to say anything about what you know already and what you, I mean, there has been so many really sharp insights, very good overviews also, which relate the field to the general knowledge. I've really been impressed by some of the, by many of the presentations. There are a few things which I'm not going to say I have questions, but it's really questions. You know, where is it and what is different in India from elsewhere? I think one which has been very much addressed is the private and public differences. What strikes me here is that the private and the public is seen as really separate, and maybe it is the case, you know, that the private here really is profit-driven, but in many other countries, the private providers are actually the largest part, but they are not private in the sense that it is often interpreted here, apparently, but really private but publicly oriented, as we call it. NGOs, faith organizations, charities, even individual private practitioners, which, as Anne Mills has said also, but also in Belgium, even at the hospital level, they make up by far the largest part of the health providers, and the challenge is the regulation, the management, and I wonder where in India this in-between situation, what the role is or could be in the management of the health system or in building up performant health systems. Another thing, I mean, there have been many sciences, as you say, in this meeting, but what I've sometimes, I'm not going to say missed, but where I wonder, because we are in a country of great companies and so on, is the management sciences. The formal management sciences, one thing which strikes me in all the discussions I have got is the, I mean, I know it's not a nice word also in academic circles, but where is the line management definition? Who, I mean, the accountability, the responsibilities, the roles of the line managers, which are quite blurred. Local health workers are responsible for one thing, but there are other things which are dictated from above. And particularly the program spirit has stricken me and has not always been as visible here at the conference as it is apparently in the field. But again, I think another aspect which tends, and rightly so maybe, is sometimes not so highlighted in health systems research is truly the biomedical and the epidemiological sciences. I mean, we have discussed here a lot about programs, But in the field, you know that, and when I talk to the researchers, and there are parts where, for instance, there's enormous amounts of resources still being put in malaria control, whereas there is almost no malaria anymore. And so these epidemiological questions also have an impact on health systems. Okay, I think I'm going to stop here, but let me say I have really spent 4 very intensive, very interesting days. I really am very happy with also the support that the modest support we are able to give to the IPH. If I would speak in old terms, I would say there's a high level of donor satisfaction, maybe not so much from my part, but I will transmit it also to the Belgian Development Corporation. But I think really all the credit is due to the team of DEVA, the IPH, and the many organizations and authorities that are represented here. And thank you very much for the privilege of being here. And I look forward to be back for longer times. Thank you.
Thank you, Bruno. Floor is yours, Dr. Bima.
Thank you. I would like to compliment the organizers for the perfect way that this entire workshop has been organized, and I would also thank the organizers for an opportunity for this interface. As a policymaker bar implementer, the take-home messages which I take, apart from all that has been outlined by Sri Devadasan, I would just like to underline the important points from the policymaker's point of view. We are speaking about universal health coverage, which is the path to UHC is fraught with challenges, because UHC itself is a very complex set of variables, as we have discovered in the past 2 days. Every point, every set of variable being discussed and debated at length. We have spoken about the human resource constraint when we talked of be it from the provider point of view or be it from the purchaser point of view. We have to evolve strategies to retain our human resources, to provide human resources to the rural areas of the country. We also require to have treatment protocols in place, referral protocols in place, so that our district hospitals, our tertiary care hospitals do not become overburdened, and we ensure that the primary care facilities are properly utilized. We also touchingly mentioned upon the use of generic drugs. But ultimately, all these have to be driven by governance reforms, administrative reforms, which ensure transparency, which ensure flexibility at the field level, and to decrease the distance between the planner and the implementer. For that, today we discussed on the information systems, the monitoring methods, and the need to link monitoring methods to deliverables or outcome factors. These are the points I've seen from the policymaker bar implementer point of view. A lot of discussions, a lot of learnings have come through the entire 2-day sessions. I thank the organizers for this opportunity.
Thank you, Dr. Bina. Now the floor is to Dr. Sundara Rama.
I would like to join the others on the panel on congratulating the organizers for an excellent conference. No doubt this has emerged now as the premier conference in India on health systems as a theme. I don't think there is any other comparable conference now. And it's also bringing together an enormous number of young researchers and looking at new questions, looking largely at questions that have arisen from and during the process of implementation, and looking at it with new insights. And I should also mention the excellent arrangements that have been made over here at the conference, and the affection with which the volunteers of IPH have been managing the thing. Everybody feels very well cared for, and a certain degree of closeness with the team over here. I think this has been a really exemplary conference. I attend a lot of conferences. In my line of work, I attend a lot of conferences, and I can tell you this is one of the best I've attended in recent times. I would say that in this long list of things that need to be a focus of research questions, I would like to add or perhaps elaborate on a couple of issues on the major theme. And perhaps the one that I think we need to collectively work on, all the 333 you said who are here, in some sense, who would work on, is to really look at the evolution of measures of the progress towards universal health care. There are many reasons why we must prioritize this, because many ways of defining universal health care merely prioritize certain methods or mechanisms of purchase or delivery without really looking at it in terms of the basics: access, financial protection, health outcomes and health status, and quality of care. If you could say in these terms what systems work, then one would wonder, for example, like if you would compare Sri Lanka with either Himachal Pradesh or Kerala, why we would not say we are on comparable levels of universal health care in many of these situations. In some sense, Himachal, even financial protection in many areas would be substantial, but maybe one could need to work on that. But there are areas in which the measures of healthcare, I think, would remain a major challenge. It's not about whether that example may be wrong, one has to think a lot more on this, but the issue which I am trying to flag is that we need to actually know that. Having done that, we also need to develop tools by which these measures can actually be measured in decentralized ways, and feasible to measure. I saw Devdas had some interesting thoughts on that. Muralidharan had presented on that in this theme. There were many others who were using measures, mechanisms of measuring, monitoring information systems in the role of measure. And this is some area that I think we should set ourselves. Because I do suspect that we'll have to do something very explicitly Indian, but that would have an universal application. Because our history has been to strengthen a public sector delivery and free care in the public sector delivery, and we must be able to construct a method that can capture that. And I think that it would have relevance, as I can see it in many countries across the world. So there is one area that I think, but other than that, I also think that we need to sort of get a better grasp through pilots, through our work on the cost of what this whole progress will take, and what would be 4 units of progress, what is the sort of what is the sort of outlay that we really require, because though we are using different figures, we will require that. And that would again mean not only financial resources, but I think there's a lot of work to be done on human resources and defining them. But that I think has come out very well on the paper. So I think we have just begun into an exciting journey, and there is great potential in the path in which we have started moving on. Thank you.
Thank you. Dr. Ravi Narayan.
I would also like to start by adding my sense of both gratitude and thanks to IPH for bringing together such an interesting set of people, 333 as we are saying, from all over India and from many parts of the world to discuss health systems research. Unfortunately, I missed yesterday, but today was really, I feel even worse that I missed yesterday because today was such an interesting day. I just want to share a few thoughts as I listen to the list that Deva made, because it just so happens that my mandate on the steering committee of that conference was to do 3 things. And I'm going away very, very sort of thrilled at the experience here, because I think those 3 things happened here. The first was to increase the presence of, at the international level, global South researchers. And here when I came and found so much data and evidence from the South, the disadvantaged parts of our country, from states, from the Northeast, from Jharkhand and Chhattisgarh, I feel we are really beginning to grasp a little bit of the tensions and the challenges of Bharat and not getting preoccupied with shining India. So that I think was very, very well done here. The second thing which I was asked to do was to try and increase, not just Global South researchers, but researchers from the social sciences and researchers from civil society. And here again I found that this was a very interesting conference, because like Sundar said, as you get older, one of the occupational hazards of getting older in public health is that you attend more conferences than you need to. And I can tell you that I felt that this is a very, very multidisciplinary, multi-sectoral conference. One of the reasons why we're all going away feeling that we've really discussed issues, because you'd never find in mainstream public health conferences this sort of multi-sectoral group. You have people from policy making, you have people from provision, you have academics, you have researchers, you have civil society, you have people representing corporate social responsibility, and you've got a range, you've got even people representing social movements. So you've got a really wide range of looking at the same problem. Similarly, you have multiple disciplines here. We're not all doctors here or just public health consultants. There are sociologists and anthropologists and economists and a whole range of them. So I think the message I would like to say is that this is a challenge, and especially the third dimension was to increase young voices. Here again, this has been very, very interesting. So I think I would like to just add that to the list that Deva said, if all of us can go away, presumably since we are all health systems researchers or interested in health systems, this will be on our agenda. Can we just be more multi-sector? Can we be more multidisciplinary? And can we ensure that younger voices and younger colleagues have greater opportunity to comment on what we do? I just took 3 ideas and I just want to bring up and end with that. I liked Sundari's presentation because she raised a very important question, and I like that. Why are we talking about universal health coverage and not universal health access? I think it's like so important. We've all been talking about UHC, we're all very excited and we need to be excited. But I think we must remember that C hides A, and therefore it's very important. Again, I read in another place, people worrying about, are we shifting? We're talking about task shifting, but we are role shifting also. The Asha was never meant to be a provider of care. She was supposed to be a facilitator. She was supposed to be an activist. And it was in that context that India decided to call her Asha. And Mita names the work that Sundar did, and his team did in Chhattisgarh. And we are very subtly changing that role and then complaining that the Asha wants to become a paid worker. She may not have asked for it if she continued to be an activist and a facilitator, which is what she wants to be. And that is why we contributed at a national, global level. So that's a very important question. And I would say, let's not worry about task shifting. Let's really look at roles, because human resource health is all about roles. And the last thing which I want to say is I can't help feeling that there is a danger in this new group that we are all part of, because the health systems research has such important and challenging issues that we get stuck within health systems. We have to see that health systems by themselves, whether they're traditional or modern, whether they're global south or north, are caught between 2 larger systems. One is the whole globalization that is going on, the liberalization, the privatization, and those changing economic political systems affect health systems. And the second one is that all that we are doing is trying to reach community. So I would like to leave word that when those of you who are working on health systems, can you put 2 little squares on either side of your work, globalization and its effect on what you're doing, and your action, techno-managerial, biomedical, whatever on health systems, how does it interface with the community? So if we can widen this understanding of health systems, which I find already in what Deva said was there, it was there in many lines that he mentioned, but if we can just be a little clearer about this, for younger researchers here will give slightly wider perspective for the study. Thank you.
Thank you, Ravi. I think we all agree that a lot can happen over 2 days. In the very start of this conference, I heard the description of researchers as complex and sometimes complicated people. and of policymakers as rather simple beings. After 2 days, I hear Deva saying that we need answers not only from the researchers, but also from the policymakers. This is very nice, I think. I have a question for a policymaker. You, Dr. Bima, you said that one of the lessons to take home for you is to make the distance between planner and implementers a bit shorter. Do you think that EPHP 2012 has made the distance between researchers and policymakers a bit smaller also?
Certainly.
Please extend it.
In fact, I think that was the entire point on which the last 2 days revolved. Because, in fact, I was discussing with our friend from Uganda as to what was the impact of her research, which she explained in the morning, and how was the government, how receptive was government when it came to accepting the results of research. So one point that we discussed and we agreed was, if government or the policy makers itself, they themselves want the answers, they have questions, policy makers want answers. When a new program is evolved, when a new scheme is evolved, policymakers also want to know as to what is the impact of that scheme, what is the impact it is having on morbidity rates and mortality rates. So certainly the divide or the distance has to come down, and that can take place only when this kind of convergence, the sort of harmonization takes place. So from that point of view, this has been a very important 2-day session for us, because all that you do in research is actually helping us in the policy side to help better our policies.
Is there any way in which we could improve the way we communicate our research findings with you?
Basically, we should have systems and platforms for that. As on today, you know, we talk, the institutions are different. The institutions do not speak to each other. But if at the common platform of, at least at the policy making level, we can institutionalize this dialogue, if we can create forums which can, you know, promote or encourage this dialogue, I think this can be improved.
Message well taken, thank you. There is one thing which I think was recurrent among the reactions of the panel members also, and that was the important thing of seeing numbers as important, but not the only thing. Also going beyond the numbers and looking at the quality. I would like to link that with something that what Dr. Sundaraman said, when he said that there is a need for measuring. After all, this EPHP conference is within the framing of to achieve universal health coverage in India, but also universal health coverage at large. A lot of the presentations here started with a 3-dimensional diagram of WHO, where you have 3 dimensions in universal coverage. You have the population dimension, you have the financial dimension, you have the service dimension. But maybe one thing we learned here, up and above even measures to measure these things, is that in India and possibly worldwide, we need the 4th dimension, which is the quality of these 3 dimensions, which runs throughout these 3 dimensions. Any reactions on that?
No. I think so. I think that it is important to capture quality for a number of reasons. Largely, I don't know whether I am correct in generalizing, I come from practice, I'm relatively new entrant into theory. Largely, Western theory would put choice as the definer of, and choice, competition, markets as what determines quality. And really look at different ways of capturing, making markets effective as ways, and look at concepts like exit, choice as the parameters within which quality is built. But in a system like this, where you have actually a huge human resource constraint, and where even if everybody chips in without any competition, and supplements each other, you would still be short of your requirement. It's really a luxury to talk of choice and exit as your parameters. And in an area where markets don't act, we need to build up other robust ways of ensuring quality. I think there's been some very interesting presentations in this conference, and there's a lot of interesting work in the quality domain that has happened within the last 5 years that we've not really captured, of other ways of sort of guaranteeing, being able to ensure, being able to incentivize, being able to do with salaried health workforce and the sort of quality that it provides. But again, the question will come to, if I say so, how is it my word against yours in a world where there is policy contestation? I think there has to be some ways in which we are able to capture the progress made, and that may not be numerical. It may require looks, for example, measures of patient satisfaction or measures of the dignity and the ethical nature of practice, the lack of conflicts of interest. So there may be different criteria, or even the certain degree of comfort and satisfaction that people have in a healthcare experience, or, for example, community care. Maybe just much more humane way of providing care in certain areas. So I think those are the sort of dimensions of quality that will not accept. It's not very easy to put into numbers, but they are very important nevertheless, and I think we need to find ways of capturing them.
Dr. Ravi?
I would just like to comment on your question about quality, taking from something that the first speaker who was commenting from ITM said. See, I think as health systems researchers, and we are now talking about a national network, we're all part of a much more global network of health systems researchers. I can't help feeling that there are two important things we have to be a little careful about. One is context, which is very, very different, and so we have to be very careful. And second is about culture. And I can't help feeling that unless we go back to methods that we are using in health systems research and spend a little time, I felt maybe, this may not be a criticism of this thing, but I think as a critical thing, I feel 1 or 2 sessions in future must be kept about methods. Because I can't help feeling, it's not like, here's the evidence, let's start analyzing it. But is this really the best method of, evidence gathering? Is it really complete? And who is, evidence for whom, evidence by whom, who's interpreting it? There are some issues. So I can't help feeling when you come to quality and some of these other words that we use in health systems jargon, there is a whole question of, one is methodology, and one is a question of context and culture. And I feel it is very important. The other thing which I feel is some things I really were in answering to the earlier question you asked, our friend from who's representing the policy maker. I'm very worried that there are certain ideas. I was quite taken up by your presentation from Uganda when you quite nonchalantly just said you had data which said user fees, just didn't work. And you were quite happy to share that in so many different fora. Whereas here, as you know, for many years, user fee was the mantra. Now it's the PPP. So I have a feeling health systems researchers really have to worry about context and quality. And issues like PPPs, issues like some of the latest, holy cow, have to be challenged. And this can only be done if you're a little careful of methodology. So I feel that meanings of words, methodology is an area. And maybe that's not a direct answer to your question of quality. But I feel even quality, we need to sit together and say, who's defining quality? Who's defining quantity? Who's defining, these issues? The community defining? Is the woman defining? Is the man defining? There's all sorts of issues. And I think there's a complexity of research, which I hope we in health systems research, will have the time and the energy to leave spaces for that. And I'm sure we can go ahead much faster.
This raises also, I think, I agree completely with you, but I don't have to agree, of course. This raises also a question, an issue which is quite central in mixed methods and in qualitative methods research, is that of positionality, the influence of who looks at what and who the person itself defines what will be seen and how it will be interpreted, even how the data will be generated eventually in the very beginning. Let me go to the audience. The people in the panel here, they tried to answer two questions: lessons learned for research community and lessons learned for the policymakers community. I would like to stress one more question for you. Is there any lesson learned you see for the organizers of EPHP, for the next EPHP? So I go first to the lady here in front of me.
I'd like to actually follow on something that Ravi mentioned, that universal healthcare is finally about reaching the communities. And when we are talking about pathways of getting from here to there, we have to be mindful that communities are heterogeneous and full of power dynamics and power inequalities. And therefore, I do feel that social exclusion and the ways in which the pathways that we choose to get from here to there could either accentuate these or address the gaps is, I think, is a gap that we still have to work quite a lot on. And in that context, I would like to say gender inequalities, inequalities by caste, much more research needs to be done. I didn't hear any voices addressing those. It was only maternal health, and that is not women. It is not gender either. So just to say that that's a huge area where there seems to be work needed. Thank you.
Message well taken, I think. Next one. Yes, please go.
It's been a great pleasure to come back here for the second time. My only sort of reflection on this, apart from some of the other things people have said, was since a lot of the presentations were on research, if you give more time to the presenters, most of the time given is about 10 minutes. It's very difficult to go in any depth into a research study or even discuss the findings of a research study if all we have is 10 minutes to go through the various steps of doing the research and talk about the findings. So you can have more sessions, maybe you have an extra day, but give us more time so we can express ourselves fully. Thanks.
Very briefly, I just want to add one more big topic which perhaps could be considered is on the subject of health technology assessment. It comes very much within the 6 functions and how we relate to through the performance criteria. Technology assessment. Thank you.
Okay. Anybody else? Yes, over there. Get down. Yes, yes, yes.
I think it was a great opportunity for second time to come here and share our research findings. In the afternoon, I was collecting some of the copies of that I will carry to Odisha and give some of the people who could not come here. My point was that EPHP 2010 and now we are in EPHP 2012. So can there be any mechanisms to have the post-conference discussions and follow-ups, maybe on the EPHP website or IPH website, so that we can share our experiences to work with the policymakers and implementers, and maybe some new research we are planning to do that we can share among ourselves. So can there be mechanisms to have a post-conference follow-up discussions and that kind of forum? Thank you.
I think, Dr. Kadam, that this is a splendid idea that goes way beyond what was already planned of making the live streaming into YouTube segments, which are static. This would indeed be kind of the dynamic platform that Dr. Bhima just also made a plea for, I think so. Well taken.
It was a nice experience of the last 2 days. One of the areas that well need more attention should be, I think, while we are discussing about the universal health coverage, it is a continuation to what Sundari was saying, to the conflict areas across the country. What should be the approaches for the conflict areas, wherein, whether it is, different kinds of conflicts are existing across the country, how to kind of address the universal healthcare approaches for those areas. That should be addressed, I think.
Thank you. Unhappily enough, I have to tell you that our time is running out. So I have to thank all of you for your contributions. But I want to thank some of you especially. Without the whole IPH team, this would not have been possible. I would like them, all of them, to come in front here. So please, IPH, all of you, come here. Come. Come.
Standing ovation.
Yes. You can see we're still struggling in this because we're always doing something else.
A woman should have the last word.
Am I allowed to say the last thing?
But you will never stop, you said yourself.
I have been granted the permission to have the last word, thanks to my gender, ma'am. And I would like to share something with all of you which is probably personal, but very important. I think that the atmosphere in these 2 days, which was created with a lot of love and affection. I think everyone has thanked the team. And I think there was a certain energy that flowed, which allowed for listening to happen. A lot of the conflict areas we talk about in the health systems and in the research are because people are not listening to each other. I enter a room full of experts, and they're all talking a different language, each of them. So, if in our own ways we can learn to foster this spirit of working together and take that back with us, wherever we work, because we are individuals in a much larger world, I think a deeper sort of something from this conference would go back with us. Thank you.
So EPHP 2012 has concluded. See you in 2014. Thank you.
We would like to give a token of appreciation to Dr. Beena for coming in here today, joining us and participating in this conference. Thank you so much, ma'am. It's a great pleasure to have you here. A small vote of thanks from all of us organizers. The last 2 days has been an exciting journey of understanding ways and means of operationalizing universal health care in our country. Our efforts through EPHP 2012 was to bring researchers, students, policymakers and practitioners on one platform to facilitate fact-based discussions on UHC and on pathways to operationalize UHC in India. Fruitful deliberations over the last 2 days and the discussions will continue post-EPHP. We express our sincere thanks to our co-organizers and collaborators, to Dr. T. Sundararaman, NHSRC New Delhi, Dr. Mohan Raju, KSSRC Karnataka, Dr. Bruno Grisels, ITM Belgium for organizing EPHP 2012. We would like to thank the Director General of Development Cooperation and Humanitarian Aid Belgium, Miserio Germany, Institute of Tropical Medicine, European Union for their financial support for organizing EPHP 2012. We thank all keynote speakers, chairs, and policymakers who have accepted our invitation and participated in sharing their insights regarding UHC in India. Thanks to all presenting authors for sharing your findings with us and for your interesting presentations. We thank all delegates and students who have traveled from all parts of the country to participate in this conference. We extend our appreciation to all states and central government officials for their continued support for EPHP 2012. Last but not the least, we would like to express a sincere thanks to Team EPHP who worked tirelessly over the last 6 months to make this event happen and at this scale. On behalf of EPHP Steering Committee, we would like to thank all the committee members, volunteers, support staff, project supervisors without whom organizing such a conference would not have been possible. We would also like to thank our families for bearing a constant chanting of EPHP mantra in the last few months. In the last 3 days, we have put in all our efforts to make the conference arrangements as best as possible. In spite of these, there may have been some glitches, and we request you to kindly bear with us for the inconvenience. To wrap up, let us work together to strengthen our health systems and strive to move forward in this direction. I'm sure we'll keep meeting each other on various forums. Thank you very much for being with us and supporting us. A goodbye from all of us here. Have a good day and see you all in the next EPHP.